intra-abdominal pressure can be measured from directly by putting in a catheter in the abdomen, but that is very invasive and not risk-free. Second technique which has been used is to measure the gastric pressure. But the most reliable and standard technique is to use a transbladder pressure, to measure the transbladder pressure, and simultaneously it corresponds to the intra-abdominal pressure. So how it is measured? It is firstly measured at the end expiration. It is measured at the level of iliac crest and a mid-axillary line. So I'll tell you next how it is measured. The amount of fluid which we use in this measurement of this intra-abdominal pressure is around 25 ml of normal saline. So patient is positioned supine, mid-axillary line at the level of iliac crest is identified, and then the urinary catheter is attached with a pressure monitoring kit. If you don't have a pressure monitoring kit, you can use a three-way, and you can use a three-way and connect one end of the urinary catheter to the three-way, and the urinary bag you can connect up to the other end. You can attach another three-way, and you can put in a 60 ml syringe and put it and a pressure monitoring kit, or you can put a normal saline and like we measure that the CVP set you can connect the CVP, the old traditional CVP measurement kit you can use, and you have to empty the bladder first. Then you have to zero the transducer if you are using a pressure monitoring kit. Then you have to instill 25 ml of normal saline into the bladder and clamp the urinary catheter site. You have to put in a clamp here. After you have instilled the fluid, you have to release this clamp for a moment so that the air which was there in this line goes out. After this, after 60 seconds, you have to allow the detrusor muscle to relax and measure the intra-abdominal pressure. The pressure which is coming in centimeter of water, you have to convert it into millimeter of mercury and monitor it. So what are the consequences if the intra-abdominal pressure is persistently raised? It can lead to respiratory failure. It can lead to increase in plateau pressures, increase in peak inspiratory pressure. It could lead to decrease in PaO2 or increase in PCO2 because of increase in intrathoracic pressure, because 50% of the intra-abdominal pressure is transmitted to the intrathoracic cavity. And it can also lead to renal failure because increase in intra-abdominal pressure will decrease renal venous flow, and it will also decrease renal arterial flow. Decrease in renal arterial flow will activate renin-angiotensin system, and it can lead to reabsorption of sodium and water. Similarly, in the cardiovascular system, there is decrease in preload, decrease in left ventricular function, and increase in afterload. All this can lead to basically cardiac dysfunction. And in addition to this, measurement of IVC distensibility or collapsibility index or pulse pressure variability and stroke volume variation is unreliable in cases of intra-abdominal hypertension. And this transmission of intra-abdominal pressure to the intrathoracic cavity also gets transmitted to the, it leads to elevated jugular pressure, and it also increases the intracranial pressure. So basically, intra-abdominal hypertension on ACS affects all the system: respiratory system, hepatic system, gastrointestinal system, renal system, and cardiovascular system in the body, and can lead to multi-organ dysfunction. So we have to be suspicious of it. We have to identify and monitor the intra-abdominal pressure. So what to do? If there is intra-abdominal hypertension, then what to do? So initially, we have to try medical therapies and prevent the development of abdominal compartment syndrome. We can increase the sedation and analgesia. We can paralyze the patient if the patient is on mechanical ventilation. And we can decrease the elevation of head end to less than 30 degrees. It will decrease the pressure on the abdomen and may improve. You can put in a nasogastric tube. You can put a rectal tube. You can put in a Foley's catheter if it is not there. And if there is ascites, you can do a paracentesis, and you can avoid positive resuscitating with excessive volume of fluids, and give diuretics if you think that the patient is volume overloaded and hemodynamically stable, and optimize the ventilation, And see, you don't have to uh, take the plateau pressures and CVP and CVP and pulmonary artery pressure, occlusion pressures as the reading shows. Because as I told you, the 50% of intra-abdominal pressure is transmitted to the thoracic cavity. And so the plateau pressure which has to be used is P plat minus 0.5 into intra-abdominal pressure. The P plat which is coming is actually higher. And you have to check the P plat transmural plateau pressures, which is P plat minus 0.5 into intra-abdominal pressures. So you have to see and prevent the development of ACS. So if the ACS is developed, then you have to see if the ACS is because of the primary intra-abdominal cause or it is secondary or recurrent ACS. If it is primary, you have to revise or do a abdominal decompression with basically in a surgical way. Or if it is secondary, you have to continue doing the conservative measures. And if it is not treated even after conservative measures, you have to again go for the surgery. The conservative measures you have to continue doing, like improving the abdominal wall compliance, optimizing fluid, and all that. Coming to acute mesenteric ischemia. So non-occlusive mesenteric ischemia or acute mesenteric ischemia is basically compromise of splenic circulation resulting in bowel ischemia. So the bowel, the splenic circulation takes a hit and it can lead to mesenteric ischemia. Mesenteric ischemia can also happen in other causes, like in embolic phenomena, like suppose there is a atrial fibrillation and there's a clot in the right atrium and in the left atrium. It can go into the superior mesenteric artery, or it can go into the inferior mesenteric artery. Or if there is a thrombosis, there is a atherosclerotic disease, and if there is a venous thrombosis or arterial thrombosis, it can also lead to mesenteric ischemia. But in critically ill patients, not having all this, the decrease in splenic circulation can itself cause mesenteric ischemia. The typical feature of mesenteric ischemia is pain out of proportion to physical examination. And it leads to the mesenteric ischemia leads to cascades of events leading to multi-organ failure. And so what are the causes? As I told you, any condition which decreases the blood supply to the splenic circulation, like cardiogenic shock, hypovolemia, sepsis, the causative factors or causative diseases are same in critically ill patients for causing gastrointestinal dysfunction. So low cardiac output syndrome, hypovolemia, cardiac surgery, all these factors, what they do is they decrease the intestinal dysfunction. They decrease the they cause the injury to the mucosa of the intestine, and they increase the intestinal dysfunction. They rupture the epithelial barrier. They ultimately leading to bacterial translocation and finally full thickness infarction. So how to diagnose? Basically, you have to check the WBC count. 70% or 5% of the patients of mesenteric ischemia will have leukocytosis. Lactate levels are increased above 2 millimoles per liter. The plain radiographs can be done. Occasionally, you can see an intramural gas or bowel distended bowel or bowel thickening, but they lack specificity. Computerized computed trauma, the CT scan or CT angiography can be done. This is generally to rule out the CT angiography or CT scan is generally to rule out other causes and to rule out embolic or thrombotic cause of mesenteric ischemia. And generally, the CT angiography is normal or inconclusive and non-occlusive mesenteric ischemia. This is the finding of CT angiography, CT of the abdomen, contrast CT of the abdomen showing the SMA thrombosis and superior mesenteric vein thrombosis. And in addition, you can do a duplex sonography. It is actually very operator dependent. If the sonologist is expert, he can tell you the SMA velocities and the blood flows in all the celiac SMAs and inferior mesenteric artery. Similarly, you can do an endoscopy and visualize the mucosa of the intestine. And conventional angiography is actually done very frequently in these cases. First is to check the site of thrombus or embolus, or to check if it is a non-inclusive mesenteric ischemia. And secondly, can be also be therapeutic for administering vasodilating agents like efavirenz. So here it is non-occlusive mesenteric ischemia. You can see a celiac artery, the pruning of celiac artery, the pruning of, and we did appearance of the SMA, and we did appearance of inferior mesenteric artery. These are the findings in mesenteric ischemia and of non-occlusive mesenteric ischemia. So how to manage? Basically, fluid resuscitation, minimizing the use of vasopressors, broad spectrum antibiotics, because there is high chance of bacterial translocation and sepsis, resulting sepsis, systemic anticoagulation if there is no contraindication, management of underlying disease, and then, as I told, injection of piperacillin. And if nothing works, then open surgical exploration. Coming to the last thing, the diarrhea in ICU. So basically, diarrhea is most common non-hemorrhagic GI complication in ICU population, and it results in serious fluid and electrolyte balance. And there is inadequate administration of nutritional support because in diarrhea, there is malabsorption, the nutrients are not absorbed. And diarrhea is frequently overlooked because, see, it is very difficult because the patient doesn't complain of diarrhea. And if the patient is ventilated, sedated, and the nursing officer or the physician who is taking care is also is not looking for the amount of stool or the frequency of stool. But so the accurate measurement of stool output is difficult in ICU.